seminar for this week. I'm Paul Delameter. I'm very happy to be introducing Arianna Planey. She is currently an assistant professor in health policy and management over at the Gillings School. She's also a faculty fellow at the Sheps Center for Health Services Research. She earned her PhD in geography from University of Illinois at Urbana-Champaign. And her PhD, and one of the reasons why I'm standing up here is Arianna is a geographer, and she is a health and medical geographer. And she worked with one of the best health geographers in our field as an advisor, and she's continuing on in this awesome work. Her expertise is around measuring healthcare access, healthcare workforce issues, and evaluating chronic illnesses. Her work has been published in Social Science and Medicine, Health Affairs, Health Services Research, the Journal of Urban Health, and Open Forum of Infectious Diseases. And she is spinning up a really interesting research program right now. And she is currently the PI on a Robert Wood Johnson Foundation grant. And she also has funding, I believe, from the Federal Office of Rural Health Policy and from on campus, the Lineberger Comprehensive Cancer Center. So I am very honored and happy to introduce Arianna today.
Thank you. So today I'll be talking about a couple of just sort of two broad case studies, and making the case for thinking about time as a social determinant of health. And the case study would be focused at the intersection of reality and access to care, with a focus on cancer health. The why for my work and for this work focusing on that intersection of policy, healthcare provision, time scarcity is I was reading Jamila Richard's book, Fragmented Democracy, Medicaid, Federalism, and Unequal Politics. And in the introduction on page 11, the fantastic quote just jumped out at me. You know, when those most affected by a policy are also most marginal in the polity, it is worth stopping to think about how policy and policy interact. And I thought it was a fantastic description of what health geographers do. So this is a slide from my PhD advisor, Sarah McLaughlin, who's a professor emeritus at University of Illinois. And this was the first slide she showed in her health and medical geography class, introducing a relational perspective of health geography. And so encouraging us to think about places as dynamic, but also thinking about demography, also thinking about health outcomes in the population and within population. But also thinking about, when we're thinking about these dynamics, also accounting for things like mobility, behaviors, perception, experiences, individual and social differences in place, but also thinking about ecological, historical, political, economic practices, policies, and thinking about the past tendencies in those policies, and how they basically we see inequities reinforced, even if policies are new policies are implemented. So first, thinking about time as a social determinant of health. Geographers have been doing policy engaged research for pretty much as long as the human geography has existed. David Harvey wrote probably one of the most well-known publications on the topic. But thinking about in my own work, I'm thinking a lot about how can I and others in my field do policy development work that addresses the current moment. So we're right now we are kind of in the middle of this neoliberal experimental turn in U.S. policymaking that exacts a tax or a toll on the most impoverished, for the people who can reach the burdens that are being placed on them. And there's this fantastic work coming out of sociology, political science, social policy that's focused on administrative burdens or the onerous burdens placed on people and communities' greatest needs. And what we know from that research is that administrative burdens associated with accessing healthcare services increases the risk or likelihood of forgone healthcare among Black and disabled patients. We know that, for example, in the case of SNAP and WIC, states that required in-person appointments to continue eligibility for SNAP and WIC, they actually saw a decline in the number of people who are determined to be redetermined to be eligible, because people the requirement for in-person appointments was quite difficult, particularly for moderate with young children. And in the case of Medicaid, Medicaid work requirements, we're seeing multiple states prior to the Biden administration, multiple states implemented Section 1115 amendments that allowed work requirements for Medicaid, which required up to 40 hours of active job searching. This is despite the mountain of evidence showing that people who are eligible for Medicaid are often employed already. And then also in the context of the pandemic, we've seen that cutting unemployment benefits to supposedly induce re-entry into the workforce actually didn't produce that intended outcome. And so then thinking about time is a less examined facet. We know that time is not everyone has the same, everyone has 24 hours, but not everybody has the same 24 hours. And so in policy evaluation research, we often see research that's more focused on whether the policy implemented achieved its stated aims. But there's less focus on the burdens that are imposed on people who in the most need of the services or the policy outcomes. And we also see that these inequities can arise from pre-existing racially uneven distribution of resources like healthcare, social services, affordable housing, and jobs. A really fortunate example is actually between 2008 and 2018, about 110,000 disabled people, about 1.2% of applicants, died prior to receiving a final decision from their appeal for Social Security insurance. Social Security insurance is a pretty much a classic example of administrative burden, where your first application will almost always be denied. And the people who are eventually get their application approved are those who had the social capital and the means to hire a lawyer. But they're usually having the social capital and the means to hire a legal assistant would preclude you from being eligible for SSI. So it's sort of a perverse system. And so then tying this with like thinking about structural racism. There's a growing body of research showing that racism steals our time, particularly Black, Indigenous, and non-Black and non-Black Indigenous people of color, steals our time. And so when we're thinking about structural racism, we can think about it as macro level systems, social processes, institutions, and ideologies and processes, and that social forces that interact with one another to generate and reinforce inequalities among racial and ethnic groups. And so then if we think about time, thinking of time as a social determinant health, structural racism, we also have to put that in the spatial context. So this is a paper from 2007. It talks about how space is racialized and also race is spatialized. And we see that one of the easiest examples is racial segregation. And we know that racially segregated neighborhoods often have poor access to healthcare services, disproportionate exposure to health-harming exposure, poor access to health-enabling resources and coping resources that would help them overcome those disproportionate exposures. So there's these sort of disproportionate exposure to hazards and also inequitable access to resources. And so thinking about time as a social determinant of health, but in the context of structural racism, I pulled from this work, because time is differentially allocated by race, time may account for some of the racial inequities in health. Conversely, this also implies that racial ethnic minorities potentially have the most to gain by interventions that promote time equity. And so in our work, we are thinking about spatial temporal equity. And so thinking about the need for the more equitable distribution of healthcare resources, not just more healthcare resources, but making sure that these healthcare resources are allocated according to population need and not just according to pocket prerogative. And so one way to help think about sort of situate this in like the broader context or concepts that are used in health research, thinking about like the scalar distinctions between fundamental policies and social determined code. Fundamental causes, social determinants of health, and down at the bottom, closer at the individual level, social risk and social needs. This distinction is particularly important in health services research because there's a tendency to collapse social determinants of health and social risk and social needs, particularly in research done within health systems, where there's often focus on screening at the individual or household level. And there's this tendency to conflate social determinants of health with social risk and social needs. But social risk and social needs are downstream of both fundamental causes and social determinants of health. If we think about time as a social determinant of health, we're thinking about this as also downstream from these fundamental causes, so these underlying social patterning of resources and hazards that drive health inequities, and also inequities in healthcare access. And then in the broader context of this part study, I always think about healthcare provision as spatially embedded. In the context of the pandemic, we've seen this in terms of like the use of existing infrastructure for vaccine testing and vaccine distribution. I'm sure some of you in this room do research on that. We saw like the public-private partnership with pharmacy chains with that rural communities, Black and Latinx communities and large metros were being left behind because these pharmacy chains intentionally do not place locations in these areas. And then that can also be related with the lower and slower vaccine uptake, lower rates of testing in these communities, despite the higher incidence and higher mortality. Thinking about time as a social determinant of health, we can think about time as a socially patterned resource and think about how this patterning is fundamentally shaped by the spatial allocation of resources. So think about jobs, healthcare, even childcare. And so for people of color in the US, they have longer wait times, particularly Black and Latinx people, and they also experience longer travel times to access healthcare services. And this is also true within more centralized or universal healthcare systems, like in the UK. So overall, people of color experience high degrees of time scarcity, which is partially attributable to the disproportionate occupational sorting into precarious jobs without paid sick leave. Longer work commutes, one of the spatial mismatch between where they live and where they work. So in some previous work we did, we found that long commutes, they force a trade-off between wages, commute times, and housing affordability, and particularly for disabled people of color. And in the context of chronic disease prevalence in Black and Latinx communities, time scarcity is associated with greater difficulty in chronic disease management, such as diet modification. And that in the spatial context for that is what's called supermarket redlining, where grocers followed white consumers to suburbs, leaving behind Black and Latinx communities in metro areas. And what this means is that these communities people in these communities have to travel farther to access healthful foods, on top of the time scarcity experience in terms of their work commutes. So in our from the first paper from this project, this was sort of a first stab at it, where we kind of brought together all these conceptual literatures from the different fields to make the case for an applied geography, where there's a focus on spatial temporal equity at the intersection of house and place. I'm not sure if there's much else to say here. I think I've covered a lot of what I would have said here. So thinking about measurement. So if time is a social determinant of health, what can we measure? So then we can measure things like the spatially uneven and racially disparate distribution of harmful exposures, for example, chronic stress, environmental racism, and also exposure, or and also the downstream effects of these exposures. And so then here, there's like lots of ways to think about it. You can think about dosage, you can think about duration. You can also think about time use. There's a lot of really great work in sociology, there's sociology, social work. Think about the time cost of community to work, accessing healthcare, childcare, education, and also we can even think about wages. So as I mentioned before, we noticed in our previous research, we found that disabled women of color face the most severe trade-off between wages and commute times. And there's a broader literature a rich, broad literature on spatial mismatch, particularly at the intersection of race, gender, class, and disability, that considers the time cost with social and monetary cost born of the allocation of resources that favors white and wealthy, particularly in segregated social groups. In terms of healthcare inequity, like the implications here are that, or particularly for rural residents, travel distance to care are key barriers to access healthcare utilization that not only affect frequency, timing, and cost of hospital visits, but it also affects healthcare outcomes. So downstream implications of longer travel times include increased risk of hospitalization for ambulatory care conditions, or these are conditions that can be managed or prevented with basic preventive care for primary care. Longer ambulance travel times and worse survival rates for emergent conditions like strokes and heart attacks. Delayed diagnoses and worse severity of conditions, particularly for stageable cancer. So I'm not going to get too much on this, but like in terms of thinking about time as a cost, you can actually think of time as a cost in terms of accessibility, but also in terms of affordability. So affordability doesn't just include medical costs. It includes the indirect non-medical costs of using healthcare. So time off, parking, lodging, all of the costs that come with using healthcare, particularly in the management of chronic conditions, treatment and management of chronic conditions. I'm not going to get too much into this. So in the context of this broader presentation, I'll be talking about cancer screening and cancer treatment. And so this is sort of an illustration of that broad continuum. A lot of the research is around here, screening, and screening and diagnosis gets a lot of focus in the literature, but there's also a bulk of literature focused on treatment and survivorship. Growing area is end of life care. Okay, so the first case study, we're looking at rural hospital closures, access to care, and care utilization among rural dwelling adults in the U.S. The co-authors, Arianna Planey, who's another geographer and also my husband, Sandy Wong, who's an assistant professor at Florida State, Sarah McLafferty, my former PhD advisor, and Michelle Coe, health services researcher at School of Medicine at UC Davis. And so there's a couple of studies. I'm just going to go over this first one because it lays the groundwork, but the third study is what's most relevant to this topic. So the overall, since about 1975, there's been the trend in the U.S. has been a decline in the number of hospitals in the U.S. And that decline has actually been the most marked for rural hospitals. And what we see is over time, this is over 30 years, is that the hospital closures, rural hospital closures, are having increasingly become concentrated in U.S. South region. So about almost 70% of hospital closures between 2010 and 2020 were in the U.S. South region. And they're also increasingly concentrated in rural counties with higher shares of Black residents. And so more context, particularly for the U.S. South region, we saw that between 2007 and 2008, the number of rural counties in the South with no hospital increased from 177 in 2007 to 218 in 2018. And of those, 33 lost their last remaining hospital to a closure. Relatedly, the number of closures, the number of rural counties with more than one hospital decreased as well. There was actually one county in Mississippi that had 4 rural hospitals in 2004, 2008, 7, and now down to 1. According to, so also between 2007, I'll discuss this more, but between 2007 and 2018, at a track level, mean travel distances and travel times to the nearest and second nearest hospital increased between 2007 and 2018. So to travel distance to the nearest hospital from each rural tract, from this population weighted census of each rural tract, increased from about 9.9 miles to about nearly 16 miles in 2018. And to the second nearest hospital, it increased that travel distance increased, from about 14 miles to 22.6 miles. So even this, and I'll discuss the importance of measuring access, travel distances and travel time to nearest and next nearest hospital. Most studies in health services research only focus on the nearest hospital, and they actually may be missing the most severe or the most consequential racial and ethnic disparities in travel distances or in travel burdens to access healthcare services. So it's illustrating the point earlier about hospital closures disproportionately occurring in Black rural communities. So here is the Black belt. In red are counties that experienced closure between 2007 and 2018. Prior research has shown that the rural hospitals in majority Black communities are and continue to be at elevated risk of financial distress and closure. And for this reason, we focus on the U.S. South region, which is home to about 38% of the U.S. population, but 52% of Black residents in the U.S. So here's a map showing the route to the nearest hospital, and the color indicates that the length of the travel in miles, length in miles. So the minimum was about 0.02 miles, and the max is about 50 miles. And there's one of the longest distances along the coast in Florida. Here to the second nearest hospital. But anyway, so our study area covered about 2,500 census tracts that fit within 790 rural counties. And we defined the South as a 13-state region that covers about 12.6 million rural residents. In terms of contribution of this project, we're moving away from, so in health services, like the health services literature broadly, there's still a focus on provider and facility count in that area level provider and facility count. But they don't give us a sense of the population level impacts of hospital closures, murders, and all sort of the cessation of services at facilities and what that means for the people who are served by that facility. And so by measuring travel distances and travel time, this really allows for border crossing and health services use. Also highlight within county areas closures and rural hospital closures, and also focuses on spatial access is still fairly novel in health services research. And this study can be also this approach can be extended to 75 county data pre and post closures, particularly for rural dwellings. Okay, so okay, I think I just duplicated this. So again, most prior studies on rural hospital closures have focused on area level counts of facilities and providers. But we also know that travel impedance is associated with lower utilization of primary care and outpatient settings, longer ambulance travel times, increased mortality, increased risk of death from emergent conditions. Altogether, what we're seeing is like these increased travel burdens for healthcare access healthcare services contributes to higher healthcare spending in rural contexts. And we're gonna get moving here. So the first question, we had two research questions. First study, we have two research questions. First, we are interested in whether there are racial and ethnic disparities, travel times and travel distances to access acute care hospitals in the U.S. South region in 2008. And then we're also interested in looking at, well, we wanted to look at whether hospital closures were associated with longer travel time to both nearest and second nearest acute care hospital. I'm going to keep this brief, but what we did, it goes multiple steps. So then we had to, there was a lot of triangulating. There was the closures data, hospital closures data set at the Sheps Center. We also had American Hospital Association data. We also had provider services data from the Centers for Medicare and Medicaid services. So we had to triangulate all of these data sets to determine whether the hospitals were actually open and providing healthcare services. And then from there, we were able to geocode the location, map them, estimate network travel distances and times to access nearest and second nearest hospital from each rural census tract. And we used population weighted centroid to better reflect the center of gravity, or basically where most people live, or basically, yes, population center of gravity. And then we generated descriptive statistics by rurality, racial, ethnic composition, and fit a three-level linear mixed effect model to test whether hospital closures were associated with longer travel time. So here are the maps, just sort of showing changes in travel time and travel change aspects. This one, okay, I think I put the wrong map. This one should be distance, this one should be time. But anyway. Oh no, this is for nearest hospital and second nearest hospital. So interestingly, there's a lot of heterogeneity. About half of rural tracts experience like half of rural residents in this region experience worse than access in between 2007 and 2018. This area here in Western Texas, the residents experience vastly improved access. They travel distance to the nearest hospital decreased by 127 miles because there was a new hospital constructed last year. And what we see overall is that, yes, again, about half of rural tracts experience worsening spatial access, and to the nearest hospital, and a smaller proportion experience improved access. And what we saw is that in 2018, rural tracts where residents experienced worse than spatial access to acute hospitals. They also had longer mean travel times and travel distances to access their nearest and next nearest hospital. So not only did they have worsening spatial access, but like we're also seeing a sort of a bifurcation. So places that saw better or improved access had shorter distances to begin with. And so to illustrate the sort of border crossing or the importance of understanding like within county impacts of closures, here's an example of Milam County, which had two closures. And within, so here you have two hospitals within Milam County. But then when you map like the changes in spatial access at the tract level, you see that red is worsening access, yellow is unchanged. So they were not within the county, right? You wouldn't say that residents were uniformly affected by closure, but that's typically the assumption in studies that use count at the county level. Like, oh, every resident in this county was impacted by this closure. And also, that approach does not account for spillover in the neighboring areas. So, like to the south and to the east, residents also experience worsened access because the neighboring counties do not have hospitals. So the loss of the two hospitals in this county impacted the rural counties around neighboring rural. We saw same in Gibson County, Texas, where, well, actually there were two counties next to each other. This one, Gibson County experienced two closures. The neighboring county only experienced one. But interestingly, when you look at within Gibson County, you saw we actually did see some merger activity where one of the existing facilities was moved. So residents here experienced improved access, while On top of losing the hospitals, they also lost a facility that was here was moved over here. So there's a dynamic that happens when we're only looking at count of facilities rather than looking at accessibility of the facilities. So for the model, I don't think I should go too much into this, but when we look at the outcome variables, we looked at track level travel time to near hospital and track level travel time to second near hospital. Covariates include racial place, ethnicity, income inequality, county rurality, census status between 2007 and 2018. And at the state level, we had insurance market concentration. Insurance market concentration is interesting because it's associated with higher market concentration for the hospital system, but also higher healthcare costs. And so there's sort of a complex relationship there, but we included it so that we could be engaged with that literature as well. Let's skip ahead. Overall, what we do see is that travel distances and travel time to access care increase with rurality, but when you sort of break it out this way, you're masking racial disparity, not at the hospital care. But here is network travel distances on the left, network travel time on the right, to the nearest hospital. And what we see is that across the U.S. South, residents in majority Latinx actually have the longest travel times and travel distances to access their nearest hospital, the devices and majority Black, majority white. Here's the same map, but to access the second nearest facility. And what we see here is that when you look at access to the second nearest or alternative facility, that's when the racial and ethnic disparities really come out. What we see is that residents in majority Black, majority Latinx have longer travel distances compared with residents in majority white rural tracts. And this is despite the fact that majority white rural tracts are much more likely to be remote. So what we're seeing is that these majority Black, majority Latinx tracts are typically adjacent to metro areas. And so when we did these calculations, we included all rural, urban, all of them. And so the fact that people living sort of at that interface of urban and rural, particularly Black and Latinx, will still have to travel farther to access healthcare. That's something that's often overlooked because we do know from the literature that rural hospital closures in the past decade have increasingly occurred in rural places that neighbor metro areas. And these are places where the rural hospitals cannot compete with the urban hospitals that are just a little bit farther away. They don't have the same capital, they don't have the same capacity to provide imaging services or specialized services. And so what we see in these areas is that patients actually have higher rates of bypass. So they bypass their local rural hospital and they go to an urban hospital to receive care. And that has major implications for the finances of those hospitals, which might be underlying what we're seeing here. So here's additional travel distance to access the second nearest hospital. So after you've accessed the nearest hospital, and you can't get the services you need there. How much farther do you have to travel? So what we found is that there actually about 57% of rural residents and 57% of track, or about 80% of rural residents in the region had to travel an additional 15 minutes or more. And of those, about 2.5 million had to travel an additional 30 minutes or more to get to the second nearest hospital. So imagine if you go to the ER, you think you're having a heart attack or stroke, the ER ward is closed for some reason. So then that means you may have to travel 15 or 30 more minutes to get to another ER. And what we see is that there's racial disparities here as well. So while in terms of like track level white composition, as the share of white residents increase, so does the distance between the nearest hospital and second nearest hospital increases. We see the opposite in terms of Black population composition of the track level. Interesting results for Latinx residents, where residents with a moderate share, or fact with a moderate share of Latinx residents actually have the longest distance. And in the model, we found that tracts in rural counties that without capital closures had shorter distances, or to put it another way, residents and so tracts within counties that had closures. Generally, residents had longer travel distances to access their nearest hospital. And then the more remote rural tracts had longer driving time to their nearest hospital, but the opposite was true in the second model when we were looking at access to their second nearest hospital. So these residents in these more remote rural counties that are also the widest rural counties had shorter driving time to the second nearest hospital compared with tracts within the within urban tracts that neighbor metro areas. And then in the second model, we also found that rural tracts with moderate and high shares of Black residents had longer driving time to access the second nearest hospital, consistent with the descriptive statistics. These are the marginal means, but there's an overarching point here is that ignoring access to alternative facilities for the second nearest hospital, it paints an incomplete picture of racial inequities and travel burdens to access care in rural communities. So in sum, yes, there are racial disparities in travel distances and travel times. And also the hospital closures were associated with longer traveling times to near. Takeaway, once you get this, so we can get on to the next one. So in the follow-up study, we looked at closures, travel distances, spatial accessibility to hospitals, and cancer screening received among rural dwelling adults. And so then here in the continuum, we're looking at diagnostic screening or secondary prevention. So overall, what we know is that about 37.7% of U.S. counties are classified as either whole county or partial county primary care or professional shortage areas. But we also know that the majority of these counties classified as whole or partial county primary care HIPSAs are non-metro. So then we wanted to look at, we looked at healthcare worker supply variables in these models. So we looked at supply of primary care providers and also supply of oncologists. Interestingly, when you break it down by HIPSA status, so here's not a primary care HIPSA, partial county primary care HIPSA, and whole county primary care HIPSA. What we see is that rural residents, and partial counties classified as partial primary care HIPSAs actually have the longest driving times and driving distances even compared with those in whole county primary care HIPSA. And so the research question for this study was we were looking at travel time to acute care hospitals. We were interested in whether the longer travel times were associated with lower risk of screening among rural dwelling adults. And we also curious whether hospital closures in the prior 7 years were associated with lower risk of cancer screening among rural dwelling adults in the U.S. South. The outcomes included breast cancer screening received, cervical cancer screening received, and colorectal cancer screening received. Those areas included social demographic variables, travel time estimates, healthcare supply variables, policy variables, and county closure status in the prior 7 years. This was again a mixed effect generalized linear model with 3 levels: tract, county, state. I'm not going to show the results, but here what we found was that longer travel times to the second nearest hospital were associated with reduced or lower receipt of cancer screening among rural dwelling adults. So this is going back to the point about rural dwelling patients don't necessarily use healthcare services at the nearest facility. In the context of rural healthcare, acute hospitals play an outside role for the provision of cancer screening, so that justifies this approach. And then we also found that hospital closures were associated with, interestingly, this association was not significant, but we did find that not associated. The residents in hospital closures in the prior 7 years had lower receipts of cancer screening, but it was not statistically significant. I wouldn't say in such strong terms. So I'm going to talk about this project, which is a newer project, and I don't have as many results to share, but I can talk about it. So this one is an NCI funded project. We're looking, this one was, it's a supplemental project to an existing I1. And I wanted to study, I'm studying the joint effect of financial capacity in non-financial classes care access, cancer care access among rural cancer patients, cancer patients and survivors. So this is complements an existing intervention study that has 9 sites across North Carolina, and it's a financial navigation intervention study. And so then what I'm doing is a mixed method study where I will so we have 9 sites here. So 9 sites across North Carolina, about half rural, half urban. But so rather than assigning rurality or urban status to the patient based on where they receive care, what I proposed was to look at their residential addresses, quantitatively measure their travel distances to access these cancer care sites where they receive care, and then link that with their survey responses. So they're taking at multiple points in the study. They're taking surveys about their perception of the cost of care, their ability to bear those costs, what it means, also their perceptions of their own health-related quality of life in relation to the cost of care. And so this is a mixed method study. So we have the quantitative portion where I'm measuring facial accessibility and doing a secondary analysis of the survey results. And I'm also interviewing participants to get a more qualitative, a deeper understanding of their experience of the travel burden for cancer care. Let's see. I'm trying to remember. And so I'm thinking about these costs. It's not just, I have to travel X miles to get to the facility. It's the cumulative travel time and all the trade-offs and the opportunity costs that come with that. It includes, that's also gas to get to gas for the car, cost of rideshare or cabs, parking costs. Many of these cancer centers have prohibitive parking costs. Hotel stays, particularly for multi-day appointments, or even after a procedure where one may not be able to drive. Foregone income is associated with time off. Childcare, elder care costs, foregone opportunities engaged in health enabling activities in conjunction with the side effects of treatment. And what we know overall is that cancer centers have a strong urban bias. But when you just break it out by rural urban, you really are erasing a lot of racial disparities in access to care, particularly at the intersection of race, ethnicity, and rurality. So for this study, we're focused in this part of the continuum for treatment and also survivorship and end of life care for cancer patients and survivors. I'm not going to talk too much about this one, but so I can't tell I'm colorblind, so I can't really tell what color it is. So this is I call it coral. I don't know what color that is. But these are urban sites. And then in the green, these are rural sites. And so what we found overall is that among the participants in our study, the participants actually at the rural sites had the longest travel distances. And this reflects the fact that rural cancer patients and cancer survivors are much more willing to travel farther to receive specialized care. And so that's compared with participants at these rural sites. So this is something that wasn't expected for the PIs of this project, the original parent project. They weren't expecting this finding. the intention was to assign rural and urban status based on where they receive care. But then I wanted to complicate that a little bit, and that actually really enriches the overall analysis and our understanding of the burden that these patients are taking up. And so as I'm working through this, I'm thinking about the potential for these travel burdens, broadly defined, to be moderators of that relationship between financial toxicity and patient outcomes. And these patient outcomes include treatment choices, treatment delays, care discontinuation, health-related quality of life, and survival. And one example where travel burdens are considered to be a moderator of that relationship between financial toxicity and patient outcomes is actually the choice between radiotherapy and surgical treatment for sarcomas. So actually, this relationship is actually highly dependent on the site, the cancer sites. So it's going to look different for prostate or colorectal cancer versus breast cancer, because prostate or colorectal cancer, urologists are more readily available, they're more accessible, particularly in rural places, versus oncologists who treat breast cancer. They're much more likely to be located in urban sites and be less accessible for rural patients. So, but that relationship is really dependent on the site, the cancer site, and also the distribution of the oncologist workforce. Here, also, we can think about travel burden as a mediator of that relationship. And this is a lot more complicated because it really depends on the cancer site and also the different types of healthcare workers you're talking about. So I think I'll stop here, but these were the general overall aims and hypotheses. So I don't think this one is the quantitative aim where we look at spatial accessibility. So I applied the enhanced two-step living catchment area for but using the residential locations of patients at certain sites. And then for this one, I think it is the secondary data analysis. And then, anyway, I think let's stop here until we have enough time for questions. Any questions or?
If you looked at, I mean, you know, a hospital closes, right, and travel time goes up and distance goes up, and that makes sad, but it makes sense. But what about like quality of services offered? Like if you look at maybe what's happening, of course, is they have to go a little further, but there's a lot more stuff they need, or the quality is actually better at the places they now go to. Does that temper the sort of the findings in any way, or?
So we do cite a lot of that literature. It's tricky because that quality access trade-off is well, the people who need that quality care the most are the most affected. You know, we see that like these closures are occurring in places with older population, places that already had poor access to healthcare in general prior to closures. So one of the studies I cited, actually, we found that prior to closure, actually, these places that experienced closure actually had pre-existing shortages. And so when we did like a causal study, we had to account for that free trend because, you know, and some of the methods there, so there's the assumption that, oh, well, you're gonna look at this pre-post trend, and but you're also assuming that there wasn't a trend prior to the event. But the thing is, there was a trend, like prior to hospital closures, what you usually see is an exit of surgeons, which is followed by an exit of primary care providers. And that's usually when you see the closures, the hospital closed itself, and then you see a continued decline in the number of primary care providers that goes up to 6 years, which is why I use that.
So it's like that's all related in some ways.
But yeah, you're right. There is that quality access trade-off. I didn't mean to miss your question.
Oh, yeah. Well, this was so interesting. Thank you so much for sharing it with us. One of the questions that I had is that you talked often about Latinx and Black communities. But I was wondering, have you looked, can you, sorry.
No, it's okay.
Well, so I wanted to thank you for your talk. It was very interesting and very provocative. But one of the things that I was wondering in terms of your spatial analysis, you're looking at the relationships between Latinx and Black communities and access to hospitals when they close. But I think the story might be really different for American Indian communities,
Yeah, it's
especially
very
with
different.
access to IHS hospitals, which are funded by the
Yeah.
national government, which are typically located
That's
in
making sense.
particular areas. And I was just wondering, do you know anybody working on that? Do you know much about it?
Yeah, so we did include IHS hospitals in our data set.
Okay,
But the problem was like this, with the data suppression, population data suppression, we weren't
Okay.
able to include American Indian people, population in our models,
okay,
but there just weren't enough
okay.
to do a robust analysis. But we did see some really interesting patterns, particularly, I can go back to the slide. Hopefully not too many slides. So, I did include one figure where American Indian people were included here. So we see actually, what American Indian, the sort of travel distances was greater for residents. So for tracks with the highest share or the lowest share of American Indian residents, which reflects the fact that these IHS hospitals are actually serving rural dwelling American Indian communities pretty well. I don't know if that addresses your question, the question you
Oh,
want.
no, I just wanted to know that it's something that you could do or that you're interested in or that, you know,
Yeah,
you thought of.
I appreciate that question. Thank you. Any other questions? I'll make sure. Oh, yeah.
Thank you for your talk. I was wondering if your work is curious about the nature of the closing. So if the closing was caused by something like financial constraints versus climate disaster, for example.
Okay.
And if
Yeah,
that's
yeah.
at all sort of affecting the movement of people traveling.
That's a
This
good
is like in the belt of climate.
That is a very good question. So most of the ones that we accounted for were due to financial, insolvency. Also, there are also some that were due to mergers, where a larger health system bought the facility but then closed it or ceased operations, inpatient and outpatient services at those locations. Climate-related closures tend to be temporary. I do have another project, hopefully it gets funded, but we are looking at temporary closure of facilities due to hurricanes and what that means for the short-term and long-term outcomes of nursing home visits. But yes, those climate-related, like those climate event-related closures tend to be temporary. And I make sure I didn't miss any questions online. Doesn't look like it's
Tim
there.
will come in. I think Tim will let us know if we have any.
Okay.
You know,
Someone has their hand raised.
Oh, am I okay to ask a question? All right, thanks. Thank you for your presentation. And I guess my question is a thought piece maybe. So I think we're often thinking about at the hospital closures and access from the patient consumer side. But I was curious if you've looked at how closures and locations of hospitals are impacting the workers who are there. Because I've been involved with some organizing where we've heard about huge staffing shortages across the state of North Carolina and lack of funding, especially in psychiatric hospitals. So I'm kind of thinking about how those things impact access and what you're working on, but also what the impacts are in these rural areas for the workers who actually have to be the ones staffing these locations. So I was curious if you've ever looked into that side of the care.
Yeah, that's a great question. It's not something I looked at personally, but what we do know from the literature is that prior to closure and post-closure, we do see declines again in surgeons and primary care providers. But interestingly, the one, well, so what the difference we might see in these folks like the post-closure period is that this is the composition of the healthcare workers. So what we're seeing is actually these communities that experience closures actually experience increases in the number of advanced practice registered nurses who practice in primary care.
I'm gonna pull up the chat window for you.
Okay,
We do have one more.
oh, I see now. I think I'm close to presentation. I don't know. Sure. Is there any data on how urgent care facilities are somehow somewhat replacing but not necessarily providing the comprehensive care available at hospitals? I don't know about that specifically. I don't know if there's a centralized data set for these urgent care facilities yet. But what I do know is that they're compensated differently. So like the patient costs are going to be a little different. They actually may be higher. There may be more out-of-pocket costs for the same services that they would have received at a hospital that would have been in network. So I think the difference wouldn't necessarily be in the services, but it would be in the cost of the healthcare services that rural patients are receiving. Hopefully that answers your question, Arianna. I don't know of a comprehensive data set of urgent care facility location. A lot of those are also within healthcare systems, so we might see that dynamic within the same system where a hospital closure occurred, within which a hospital closure occurred. But that's actually really, to address that question, you would have to really understand that at that hospital system level as well.
I think that's time for one more.
Yes.
Just a quick question. Do the data sets allow you to look at other services, like specifically I'm thinking of obstetric care? Are you able to look at obstetric care as a service as well as
Yeah.
cancer care? So you could look at it with these data. Have you done that?
I haven't done that, but there's folks at University of Minnesota who do that pretty much do it better than others. I try not to step on their toes because we all get money for the same pot.
Awesome. Thank you so much. Next week, we have, I think, Stan and Jay from Data Science Institute coming. So